All right. Good morning, everyone. We will get started in just another minute. We'll let everyone get settled. This is going to be a recorded video, and you will be muted. So if you have any questions or comments, please use the chat, and we will answer any of your questions. All right, well, we'll get started because we have a very packed morning ahead of us. So welcome again, everyone. I'm super excited to introduce Dr. Denise Smith. She's going to be covering today the labor induction, prevalence, trends, management, and outcomes.
Great, good morning. Thank you, CPCQC, for inviting me today. I'm really excited to talk about this topic, and I have a lot of information, so I'm going to move through pretty quickly. I have nothing to disclose. I do, however, think it's important to acknowledge that there's inherent bias that exists in all of us. And for me, in relation to the topic of labor induction, my professional background as a midwife affirms my preference for physiologic labor and birth. And in most cases, I advise against non-medically indicated labor induction. So while I've attempted to create a thoughtful and thorough lesson for you today on labor induction, I acknowledge that my preferences will inevitably come through in the way that I present this material. For this presentation, I intend to give a brief summary on the current utilization of labor induction and then move on to describing the mechanisms of labor initiation and labor induction management. And then I'll conclude with talking about routine labor induction and leave you with some more philosophical thoughts about the approach to labor and birth care in the United States. First up, let's review the current trends in labor induction. Since the early 1990s, the use of labor induction has shifted dramatically. These changes coincide with the advances in the delivery of synthetic oxytocin. And through the later part of the 20th century, major increases in labor induction was the net effect of changes to the management of comorbid conditions in late pregnancy, such as hypertension. However, along with the changes for medical management of late pregnancy have also been increases in the use of labor induction for non-medical indications, which we'll talk about in more detail later in the presentation. Of note, there is significant variation in the use of labor induction across regions of the country, by hospital and by provider type. The outcomes of labor induction that are frequently cited are the mode of delivery, vaginal birth or cesarean, its cost, the interventions used, and the patient experience. Just to highlight the variation in outcomes, a recent study of California hospitals showed that cesarean birth after induction ranged from 18.5% to 84.6% between hospitals. Along with the change in the prevalence of labor induction is also a change in the timing of labor induction in relation to gestational age. This graph, based on national vital statistics, depicts the overall increase in the use of labor induction at any given gestational age. In 1989, rates of labor induction were less than 10%. They reached an all-time high nationwide in 2007, nearing 24%, and they have plateaued since that time. The indications for labor induction are multiple. In 2014, the date of this study, the indication for labor induction was mostly medical at 60% of all inductions. Post-term pregnancy, pre-labor rupture of membranes, and hypertensive disorders were the most common indications for medically indicated inductions. 41% of all inductions were for non-medical indications. Notably, the largest increases in the use of labor induction have occurred among women with private health insurance and more education. The summary takeaway from this information is that labor induction is common. It varies significantly in its application, and it happens at earlier gestational ages. Therefore, effective management of labor induction is important in supporting vaginal birth. In an effort to provide you with comprehensive instruction on labor induction, I want to briefly review the physiology of the onset of labor. I think this will be helpful in understanding the varying aspects of labor induction management. We will start with a quick overview of the phases of uterine activity during pregnancy and their dominant hormones. For the majority of pregnancy, the uterus remains in a state of quiescence under the influence of progesterone, along with the other hormones of pregnancy. With the activation of parturition comes a decrease in serum progesterone and an increase in estrogen. This period of activation is preparation that starts in the third trimester of pregnancy, but the onset of labor does not occur until later in the stimulation phase, occurring normally at term, with the expression and activation of myometrial receptors of prostaglandins and oxytocin. The onset of the activation and stimulation of labor is complex and multifactorial, and still not totally understood. This chart represents both known and theoretical pathways for the onset of labor and represents the interplay between the fetal brain, the maternal brain, and the terminal structures of the cervix and the uterus. The mean length of human gestation is 39.6 weeks, and the majority of births occur between 38 and 42 weeks. Such a wide range of gestational ages in normal pregnancy suggests the timing mechanism is not precise and possibly is affected by a number of factors, including external influences. A complex system of multiple redundant pathways appears to regulate human parturition, making the process difficult to study. So let's talk about what we do know. The first indicators of impending labor are rises in fetal cortisol, which are released from the maturing fetal anterior pituitary gland. Increased levels of cortisol promote fetal lung maturity and alter the ratio of serum and placental progesterone and estrogen. This alteration results in an increase in prostaglandin synthesis by the placenta and the myometrium. The involvement of physiological stress pathway in the onset of labor could explain the relationship between maternal stress and reproductive failure, and the interesting possible relationship between maternal periconceptual nutritional status and the timing of parturition. Prostaglandins are known to be important in the feed-forward signal amplification and progression of labor. They promote myometrial contractions, cervical dilation, and membrane rupture. Prostaglandins can be formed as a consequence of tissue trauma or local or manipulative stimuli. In late pregnancy, prostaglandin synthesis is readily stimulated by minor local stimuli such as coitus, vaginal exam, sweeping of the membranes, amniotomy, and the dreaded castor oil diarrhea, which are all associated with inducing labor. Prostaglandins increase myometrial sensitivity to oxytocin, and they're also important in cervical softening and increased uterine contractility. A positive feedback mechanism known as the Ferguson Reflex amplifies these signals. The pressure of the fetal presenting part on the cervix activates a neurohumoral reflex whereby afferent nerves from the cervix signal the hypothalamus and increase oxytocin release from the posterior pituitary gland. Oxytocin stimulates uterine contractions and causes further release of prostaglandins from the uterus. Oxytocin is a peptide synthesized by the hypothalamus and released from the posterior pituitary gland. Endogenous oxytocin production can also be stimulated through nipple stimulation. However, it is not certain whether oxytocin is important in the initiation of labor. Oxytocin receptors are generally localized to the uterus, mammary glands, and the pituitary gland. Maternal oxytocin levels are very low in late pregnancy and do not change much before the onset of labor. Once labor has been initiated and the myometrium is activated, there is a positive feed-forward stimulation of myometrial activity. Concentrations of oxytocin receptors in the myometrium and decidua rise dramatically, 100 to 200 times during late pregnancy, so that the sensitivity of the uterus increases. This means the uterus can be stimulated by low concentrations of maternal oxytocin levels that previously had no effect. So likewise, therapeutic doses adequate to augment labor of exogenous oxytocin are very variable and that reflects the differences in individual receptor expression. So let's review how these hormones work on their target tissues. The hormonal regulation of labor has effects on three specific structures: the uterus, the cervix, and the fetal membranes. The cervix is important in keeping the fetus in utero against active and passive forces, such as the weight of the fetus and amniotic sac and passive pressure from the uterine wall. During pregnancy, the cervix increases in mass, water content, and vascularization. For the fetus to be expelled, the cervix must first change from a relatively rigid to a soft, distensible structure. Myometrial contractions exert a slow, steady pull on the cervix, resulting in cervical stretching and with little rebound between contractions. This leads to progressive cervical dilation. Cervical ripening and distension begins several weeks before delivery and involves biochemical changes in the cervix that are mediated by both hormonal and mechanical factors. Ripening and dilation are inflammatory processes that involve changes in collagen, extracellular matrix proteins, glucosamine glycans, and smooth muscle, and includes enzymatic degradation of collagen and a loss of collagen elasticity, overall resulting in a reduction of the tensile strength of the cervix. Prostaglandins have a localized influence on cervical softening. And then there's the uterus. The uterus's myometrium excitability is analogous to that of the heart in that it appears to be intrinsic pacemaker activity. It's dominated in the fundus, and it's similar to the peristaltic waves that are generated by smooth muscle and other viscera. If the wave pattern of uterine contractions is abnormal, for instance, if the lower uterus contracts first or the most strongly, the waves become erratic and uncoordinated, and labor does not progress efficiently. This fundal dominance is established in the active first stage of labor. So incoordinate uterine activity is often observed in non-established labor. This will become important later. The upper part of the uterus does not relax fully between contractions, but retracts instead. This means that the muscle fibers do not return fully to their original length, but progressively and gradually get a little bit shorter and thicker with each contraction. This means that the less active lower uterine segment is pulled up towards the shortening upper part of the uterus as labor progresses. The weakest points are the os and the cervix, which then become effaced and dilated, enlarging the opening of the uterus as they become incorporated into the lower uterine segment by the exertion of the myometrial fibers. So as the lower segment stretches and the cervix starts to efface and changes its position, the chorion becomes detached from the uterine wall. The membranes are extruded through the opening cervix by the pressure of amniotic fluid. The head of the fetus tends to act as a ball valve, separating the amniotic fluid pushing through the cervix, thus creating a forebag from the remainder of the fluid. The forebag transmits the pressure generated from the waves of the contraction and spreads that force evenly over the cervix, which aids its further effacement and dilation. The hindwaters help to cushion the fetus from the contraction pressures and then evenly distributes that pressure by the amniotic fluid. As the fundus exerts pressure on the upper aspect of the fetus during contractions, the pressure is transmitted through the fetal body to the lower segment and the cervix, and it facilitates flexion of the fetal head, particularly into the occiput anterior position. As uterine contractions progress, the pressure of the fluid in the forebag rises and the membranes tend to rupture. So in spontaneous, uncomplicated labor, this tends to be near or at the start of the second stage of labor. When the fetus is in an abnormal position, such as having a deflexed head or occiput posterior, the pressure on the forebag is not as great because the presenting part does not plug the cervix as effectively. This explains why a soft or floppy bag or leaking fluid in the second stage is associated with abnormal positions. Okay, so let's take a breath. Whew, that was a lot. So now now that we have a basic understanding of the very complex parts of the initiation and progression of labor towards birth, let's talk about the recommendations and how this affects labor induction management. For this portion of the presentation, I refer you to the California Maternal Quality Care Collaborative's algorithm for the management of labor induction. The algorithm is based upon most recent evidence, of which I will go through bit by bit. And we're going to start with talking about the Bishop score. So a key and essential element of successful labor induction starts with the Bishop score. It was originally developed as a prediction tool for the onset of spontaneous labor. The Bishop score ranges from 0 to 12, and it's a reflection of the ripening process that was described a second ago. It tabulates a score based on the station of the presenting part and 4 characteristics of the cervix: its dilation, effacement, consistency, and position. An unfavorable cervix, especially at term, has been demonstrated in randomized trials to serve as a more general marker of the risk of cesarean delivery, regardless of whether labor induction or expectant management is undertaken. The cutoff score noted here for nulliparous women greater than or equal to 8 and for multiparous women greater than or equal to 6 is based on several studies. The Bishop score is important information in guiding the plan of care and should be considered when consenting for the procedure. It should also be used during the labor induction process as an endpoint determination of cervical ripening and before the initiation of oxytocin or amniotomy. The next critical element in labor induction is the process of cervical ripening. The remodeling of the cervix is necessary prior to the stimulation of uterine contractions. Exogenous prostaglandins induce cervical ripening by relaxing the smooth muscle of the cervix, enhancing the collagen degradation, and increasing hyaluronic acid and other matrix proteins. Common prostaglandin analogs used for cervical ripening include misoprostol and dinoprostone. Misoprostol can be administered vaginally, buccal, and orally. And the advantages of vaginal and buccal administration include the elimination of the first pass effect that you would get with oral. Dinoprostone is available commercially in gel and vaginal insert form. The insert is placed in the posterior fornix of the vagina behind the cervix and can remain in place for 12 hours. The gel form is placed intracervically and can be repeated in 6 hours. Both of those preparations require refrigeration. In nulliparous women, vaginal dosing should be repeated up to 7 doses of misoprostol until cervical ripening is achieved, a Bishop score of at least 8. Both preparations of prostaglandins are contraindicated for use in anyone with prior uterine surgery. In studies, vaginal misoprostol was associated with the shortest duration interval from administration to delivery. And recent studies show no difference in uterine hyperstimulation between vaginal and buccal preparations. However, in the presence of rupture of membranes, oral or buccal administration may be preferable to vaginal administration. Also in cervical ripening includes membrane sweeping. Sweeping membranes is an intervention whereas 1 or 2 gloved fingers are inserted through the cervical os in order to separate the amniotic membrane from the lower wall of the uterus. Sweeping the fetal membranes causes an immediate release of prostaglandin metabolites. Inside the cervix, these prostaglandins act the same way. They degrade the extracellular matrix of collagen fibers, causing them to become more loosely organized and pliable. Antepartum membrane sweeping in people who are rectovaginally colonized with group B strep appears to be safe and does not adversely affect maternal or neonatal outcomes. Studies do not support any benefit of repeated membrane sweeping, and in nulliparous women, membrane sweeping has been associated with a 32% increase in the onset of spontaneous labor within 48 hours. It should be considered and offered to women using shared decision-making, and it should be noted that the procedure can be very painful for many women, and that should be explained ahead of time and informed consent obtained. Membrane sweeping can also be done on admission to the labor unit as part of the induction of labor process. Mechanical methods of induction, like the cervical ripening balloon seen here, work by softening and stretching the cervix, exposing the endometrial decidual cells, and stimulating the release of endogenous prostaglandins. There are 2 devices commonly used: a single balloon device, which is a Foley catheter, and a double balloon device, brand name is the Cook. Studies note that there are no difference between these catheters in regards to their effectiveness, major adverse events, or neonatal outcomes. The key benefits of cervical balloons compared with prostaglandins are their localized action with few systemic adverse effects and their ability to be discontinued easily. For these reasons, cervical balloons are the primary cervical ripening method used in outpatient settings or among people undergoing trial of labor after cesarean birth. Several studies have evaluated the volume of the saline in the bulb. Fill volumes of 60 to 80 mLs have been associated with the shortest duration from initiation to birth. Other studies have evaluated the question of, do you place tension on the bulb versus no tension? The verdict is, while that it shortens the length of time that the bulb is in place, it does not have an overall effect on the interval to delivery. And then there's the combined methods. Rewind, talk about oxytocin as cervical ripening. So there's been lots of speculation of using low dose oxytocin to make the cervix more favorable. The evidence does not support that this is in fact effective. And considering what we just talked about with how cervical ripening works, it's not effective. But oxytocin, how it works is it increases the myometrial cell spike activity and it alters the calcium influx through calcium channels. And so effects of the oxytocin on uterine activity depend on the concentration of oxytocin receptors in the myometrial cells, the number of available receptors, the receptor affinity for oxytocin, and the metabolic state of the myometrium. So plasma concentrations of oxytocin are usually twice that of the infusion rate. So for example, your pump says 20, the plasma rate would be 10. The physiologic response to synthetic oxytocin is highly variable and is based on the activity and action of enzymes and oxytocin receptors. And it's also influenced by maternal age, parity, gestational age, and other metabolic factors such as obesity. Therefore, people can respond widely to different, have different contraction profiles to the same infusion rate, even when their Bishop's score are comparable. Therefore, close observation during synthetic oxytocin infusion is necessary to protect the laboring woman. A summary on the recommendations on the use of synthetic oxytocin. The response to contractions for most women occurs between 11 and 13 millinunits per minute. So and also worth noting is the body progresses into active labor, endogenous processes often take over and the administration of exogenous oxytocin can be reduced. Similarly, after rupture of membranes, endogenous processes take over and oxytocin can be reduced. So it's worth considering adjusting your protocols to titrate after the onset of active labor based on contraction patterns. A few other highlights from the literature. There is no such thing as pitting through a low amplitude, high frequency contraction pattern. If you refer back to the slide where we talked about how the uterus is affected, uncoordinated contractions are actually a sign of the body not entering the active phase of labor. All right, then there's amniotomy. Artificial rupture of membranes is often used during induction in combination with other agents to stimulate uterine contractions. When performed after cervical ripening, amniotomy can release accumulated endogenous prostaglandins in the amniotic membrane forebag to the nearby uterine decidual tissue, thereby dramatically heightening the contractility and labor progression in a positive feedback manner. Early amniotomy has often been discussed over the years, and it may advance the labor process and shorten time to birth when it's used after moderate cervical ripening and in combination with oxytocin. However, what has been debated is the use of amniotomy with an unripe cervix. And so far, the literature does not support early amniotomy in the presence of an unripe cervix. So here are a few more pearls that I pulled from the literature, which may be affirming or contradicting to many of the practices that we currently use. Of note, there is no literature that identifies the maximum dosage of Pitocin. However, there are professional guidance statements from ACOG and AWAN on what the maximum dosage should be, which they are contradictory to each other. You can lower the dosage of Pitocin. And then there's also literature that supports that lower doses for longer of Pitocin are more associated with having a normal fetal heart rate than having high doses with abnormal fetal heart rate effects. And then it's important to remember that after you've achieved active labor, that the management of labor should progress in the same manner as a spontaneous labor. The key distinctions between induced and spontaneous labor is really the length of the latent phase of labor. So after this, you should use your standardized protocols and your best practices for the management of labor and the second stage of labor. So revisiting the induction of labor algorithm from the California group, the key decision points are first to determine whether you have the need for cervical ripening and repeating cervical ripening to achieve a Bishop score of 6 or 8, depending on parity, and then begin the initiations of contractions with oxytocin or oxytocin in combination with amniotomy and titrating your Pitocin to a contraction pattern. And of course, there are some nuances to these interventions, and so I'm going to review a few of them. First, it's important to engage in the process of shared decision-making with your patients. The medical indications for induction should be discussed with the woman and her support persons. The risks and benefits of each proposed agent or technique should be thoroughly reviewed, and the woman's preferences should be taken into consideration. The discussion should be documented in the health record. Risks of labor induction include a longer length of labor, increased pain, the risk of having too many contractions and an effect on the fetal heart rate. The alternatives, of course, would include spontaneous onset of labor. There are some useful tools that can assist in providing more specific predictors on the success of labor induction. Like this nomogram, for example, is one that takes an assembly of studies on the probabilities and helps calculate an overall probability score towards vaginal birth. And then there's racial equity. I think it's important to mention that there's a significant body of evidence that reports the inequitable application of labor induction for non-medical indications. Non-medically indicated labor induction is offered more frequently to white women. Meanwhile, Black women are more likely to experience cesarean birth after labor induction compared to non-Hispanic white women. However, a study that applied a standardized protocol for labor induction reduced racial disparity in cesarean following induction. This highlights the significant role that racial bias plays in our management of labor and birth. For pre-labor rupture of membranes, management of labor induction can also be guided by the favorability of the cervix. The question of using cervical ripening balloons in the presence of rupture of membranes is questionable, as the association with intrauterine infection has been established. However, the use of prostaglandins has been supported in older literature, primarily oral use of misoprostol. For women with a favorable cervix, initiation of oxytocin makes the most sense. Another special consideration is induction of labor in women with prior cesarean. The best outcomes for prior cesarean include a prior vaginal birth, a favorable cervix, and the no use of prostaglandins. And in women with an unfavorable cervix, cervical ripening with a balloon has mixed results in studies. And for women with a favorable cervix, the evidence supports use of low-dose oxytocin and amniotomy for management. Post-term pregnancies. Fetal and neonatal mortality and morbidity increases after 42 weeks, often as the result of the effects of prolonged gestation on the placental morphology. Post-term pregnancies are associated with increased frequency of both intrauterine growth restriction, fetal distress, meconium aspiration, and intrauterine death. The body of literature overwhelmingly recommends birth prior to 42 weeks. Maternal BMI has a significant effect on plasma levels of oxytocin, the length of labor, and cesarean after labor induction. The evidence supports that women with elevated BMI should be allowed more time to progress from latent to active labor They should have more time allowed in active labor to progress to the second stage. Compared with women with normal BMI, women with elevated BMI can require more doses of prostaglandins and higher doses titrations of oxytocin to achieve active labor. And then there's failed induction. Of course, vaginal delivery is the goal of the induction process, and no universal standard exists for what constitutes a failed induction. Investigators have proposed that a key principle is to allow adequate time for cervical ripening and the development of active phase labor before diagnosing failed induction. The optimal time in the latent phase should be a balance between the chance that a vaginal delivery will occur in relation to the chance that excess morbidity will accrue. Failed induction at term should be reserved for patients being induced who never progress to active labor. Studies have evaluated the association between the duration of the latent phase of labor and obstetric outcomes, have attempted to determine that the conditions under which a failed induction should be diagnosed. In one study requiring a minimum of 12 hours of oxytocin administration after membrane rupture before diagnosing failed induction led to vaginal deliveries in 75% of nulliparous women. And a workshop convened by NICHD, SMFM, and ACOG proposed that failed induction should be defined as failure to generate regular contractions approximately every 3 minutes and failure of the cervix to change after at least 24 hours of oxytocin administration. If safe and feasible, membranes should also be ruptured. Of note, the time for cervical ripening is not included in calculating the length of induction or in diagnosing a failed induction. It's also important to acknowledge that the management of pain, anxiety, and fear are other important aspects. There's a relationship between the pain receptors and the touch receptors at the level of the spinal cord. The pain gate control theory suggests that interneurons in the brain and spinal cord regulate the conduction of the ascending afferent nerves. Input from touch receptors can inhibit the impulses from pain receptors, acting as a gate. So this means that aspects of like touch, massage, and other things can inhibit transmission of pain to the brain. This explains the relationship between psychological factors and pain perception. If a laboring woman is feeling relaxed and confident, the descending inhibition is high, so less pain is perceived. And if she becomes tired or anxious, the descending inhibition is reduced. Contractions can be temporarily abolished by emotional disturbances, such as the move from the home to the hospital or the change in shift. So takeaways to manage pain. Well, I also thought it was important to acknowledge that there is use of alternative methods to induce labor. And I kind of made a joke earlier about the dreaded castor oil diarrhea, but I think this is one thing that happens often with patients that they don't necessarily tell us when they show up at the hospital. Most complementary and alternative medicines used for induction of labor have been recommended on the basis of traditional knowledge rather than scientific research. I don't think anybody's going to fund $1 million study on the use of castor oil. But the clinical evidence is sparse. There is some data that supports the use of breast stimulation in the induction of labor. There's also a small amount of literature about acupuncture or raspberry leaf. Castor oil is probably the most common thing that we see, and its mechanism of action is it stimulates the bowels, and the bowel stimulation releases prostaglandins, which then can have an effect on the nearby structures of the cervix and the uterus. So in the last few minutes here, I'm going to talk just about the routine induction of labor. There is a significant amount of existing literature that led up to the performance of the ARRIVE trial. And the literature that's presented builds upon two principles: that the neonatal and fetal risks significantly increase with the length of gestation, and that labor induction will mitigate these risks while not contributing to an increase in cesarean section. So the primary outcomes of these studies was a composite perinatal risk to the neonate or to the fetus. And secondary outcomes included patient satisfaction, cesarean birth rates, postpartum hemorrhage rates, and perineal lacerations, among others. A Cochrane review, originally published in 2006 and updated in 2018, affirms these same ideas. This review compared outcomes of expectant management of pregnancy to labor induction less than 41 weeks. And their conclusion was that the optimal timing of labor induction is still not yet clear, but the risk of increased cesarean birth was not present. What's important to note is that the two comparison groups in all of these trials, including the ARRIVE trials, was designed to be prospectively controlled. Because you cannot predict the onset of spontaneous labor and it can only be evaluated in retrospect, it doesn't make a suitable comparison group for an experimental design. So what should be noted is that in each comparison group, there were women who were induced and went into spontaneous labor. The ARRIVE trial was sponsored by NICHD and organized through the Maternal Fetal Medicine Units Network. It's a randomized control trial of low-risk women. The trial did not include a specific induction protocol, but it did distinguish that a Bishop score of 5 was necessary to achieve cervical ripening. They also, but the study did outline a clear definition of failed induction. They did not specify a time limit for active labor or for rupture of membranes. 22,000 women were eligible to be enrolled in this study. Of them, 27% accepted enrollment in the study. So the final sample size was 6,000 women. The results of this study are that there was no difference in the neonatal composite outcome, and there was significantly lower rate of cesarean birth in the induction group, 18.6% compared to 22.2%, so a relative risk of 0.84. There was no difference in operative vaginal delivery or chorioamnionitis between the groups. There was an increased rate of hypertensive disorders developed in the expectant management group, or the group that stayed pregnant longer. The conclusion is that labor induction is not independently associated with increases in cesarean birth. However, limitations of the trial should be noted. First of all, it was not a blinded study, couldn't mask whether or not somebody was having the intervention. And despite its size, the trial wasn't powered to detect differences in the infrequent outcomes, such as adverse perinatal outcomes like death. Third, it was unclear whether the results are broadly generalizable. The inclusion of both university and community hospitals throughout the United States and a variety of obstetric providers was present, but there was an absence of a single protocol for induction or labor management. So it suggests that the results are probably generalizable to similar centers. But one of the key issues that comes up is the nature of medical research in general. So medical research is largely based on reductionism, where a problem is broken down into its simplest components, and then they're examined, the information gleaned, and conclusions are drawn in a linear cause and effect relationship. And much of medical decision-making has incorporated this evidence into practice through a series of reductionist conclusions of linear cause and effect. So with the ARRIVE trial, we take two simple reduced ideas, the mode of delivery and labor induction, and then we draw conclusions about cause and effect. However, I have a simple exercise that I want to share with you that challenges this idea of thinking. So I want you to take a second and look at this photo and tell me about, or think about, what you know is associated with the outcome of this delivery. And so, I'm going to share those with you. So give you just a second. What the literature supports. So the evidence suggests that all the things listed in the margin here are associated with the delivery outcome of vaginal birth. And what this is pointing out is that this is a complex system at work. And so when we consider the limitation of reductionist studies and their applicability to real world circumstances, we have to think about the interdependence between the components of all of this system, and that the interactions between the people and the events can occur sequentially or simultaneously. And so purely independent effects are not found in the real world. Some questions are better answered through the realist evaluation or even the natural experiment. And the randomized control trial does not allow a researcher to identify the dynamic interplay between the intervention, the actors, the context, the mechanisms, and the outcomes. So when we talk about how we perceive induction of labor, it's not just the idea that the intervention, it's the people who carry out the intervention and the setting in which they carry them out. And so I'll just briefly demonstrate this through the body of literature that exists on what other things are associated with induction and outcomes of birth. In 2016, a predictive model of cesarean birth after labor induction included the following predictors: that labor induction outcomes were affected by maternal height, BMI, Parity-Bishop score, gestational age, and fetal size, all like we had talked about before, and the provider's overall cesarean rate, which was the most significant predictor of whether the patient would have a vaginal birth or cesarean. Similarly, the hospital birth is also a significant predictor. In this study of the utilization of labor induction management showed that labor induction was more likely to occur in community hospitals compared to university settings. And then in a study published in the Journal of Midwifery and Women's Health, our team investigated the use of labor induction and outcomes in hospitals that had midwives compared to hospitals without midwives. In this approach, the outcomes of our study showed that cesarean birth was lower and induction of labor lower in hospitals that had midwives. Similarly, in 12 centers in the Consortium of Safe Labor, the outcomes were similar. In hospitals, over to the left, that had lower rates of in labor induction and higher rates of spontaneous labor, overall cesarean rates were lower. So what we get to is that the ARRIVE trial actually brings more questions than answers. And so if induction of labor isn't associated with an increase in cesarean birth, then why is there association between high rates of labor induction and cesareans in hospitals? And what is it, and why do some women go into labor on their own and why do some women not? And are there benefits to the spontaneous onset of labor? This, of course, highlights our greater need for implementation research in labor and birth care. And what if you can't control for everything in a study, or maybe you shouldn't control for everything in the study? And maybe the intervention isn't the issue, but it's the people doing the intervention. Even good evidence can lead to bad practice if applied in an unthinking way. So some considerations for your approaching routine induction of labor. What is the culture of birth in your facility? And do you effectively support vaginal birth? The evidence suggests that if you're good at vaginal birth, you'll also be good at vaginal birth following labor induction. Are the results of the ARRIVE trial generalizable to your facility? Do you acknowledge that there are benefits to physiologic birth? And is your cesarean rate lower than 20% or higher than 23%? These are just all things to consider. But I also want to put a plug out there that there is value in physiologic birth. During physiologic labor and birth, oxytocin is released into the blood and the brain, and high oxytocin levels are associated with many positive effects in the mother's brain during labor and preparation for motherhood. Oxytocin release reduces anxiety and stress and pain and switches on brain pleasure and reward centers. Hence our experience that as soon as the baby is born, a mother switches moods almost immediately. And it makes a new mother relaxed and happy as she meets her baby for the first time. So putting this all together, labor induction is a common procedure and effective management is necessary to achieve vaginal birth. Favorability of the cervix is the most significant predictor of labor induction outcomes. Therefore, cervical ripening becomes the most important aspect in the initiation of labor induction. And you should delay the start of oxytocin and amniotomy until you have reached a favorable place of the cervix, 8 or 6, depending on parity. It's helpful to use established checklists for management of induction of labor. And while induction of labor is not associated with increased cesarean birth, hospitals with more inductions also do more cesareans. Therefore, a culture of care that supports vaginal birth and is more selective in the use of elective labor induction will likely have more optimal outcomes. So I'm ready for questions, and I do have a very, very large reference list that's available to you all.
Great, Dr. Smith, we do have a question in the Q&A section. I can either read that, or if you want to read through, and the question is from Dustin, and we can certainly
yeah, I've got it pulled up. So let's see. I've asked to mechanical ripening is beneficial. The practice of taking off Leo. Okay, yeah. So I didn't make a slide on this, and I probably should have, but there is a body of literature about the combination of balloon and oxytocin, balloon and misoprostol, oxytocin and misoprostol, and the evidence is pretty clear, especially evidences of late, that there is not a benefit to cervical ripening in combination with uterine contraction stimulation. The effects really are the combination of ripening together, so misoprostol combined with the cook, as opposed to using the balloon and oxytocin together. Does that answer your question? Yeah, misoprostol and balloon. Yeah, and so there have been several studies that have evaluated balloon and oxytocin together and have found no difference in the interval time to delivery.
Yeah, that actually answered my question. Thank you.
Okay, good.
In your list of references, if those studies are among them, that would be great.
Yes.
That would help. Thanks.
Yeah, I've actually got a great reference that I will share with Jamie and the team to distribute to you all. It's a recent review of the literature that does have tables of all of those different types of studies that I think it's a easy read, it's a good read, and very summarizing as well.
Great. Any other questions? And feel free to raise your hand. We can keep our eyes on you and have you come off mute if you'd rather verbalize it, or if you pop it in Q&A. You can also pop it into chat. We're not as formal today, so either of those options in the bottom of your bar could be used. Great. Stefka says, thank you. Good talk. All right. It looks like we have another question coming in. How did the ultrasound assessment of cervical ripening vary across settings in your data and publication? I published a paper ultrasound assessment compared to Bishop's score in the induction of labor.
Yeah, there's still it's interesting that, so to give everybody a little, I think what you're referring to is a measurement of the cervical length and then the angle of the cervix. Is that correct? And there's still some mixed data on whether ultrasound assessment of the cervix is related to its ripening. So, that's kind of my answer, is that it's mixed. I don't know what the outcome of your particular study was, but
thank you. Thank you for your answer. So in the data you have, I wonder the hospital may not just use modified source score, because they may use the ultrasound assessment to make a decision for the cervical ripening and the plan for induction of labor. So did you remember there's such a measurement in your data? I guess it's the data you have in that publication was available data, existing data, right? Secondary data analysis, or
yes,
did you collect the data?
Yeah, a large proportion of the studies, aside from the ARRIVE trial, use retrospective data. Yeah, and so and even the modified Bishop score, the use of the modified Bishop score is highly variable across those publications. And so the full Bishop score is what you'll see more often referred to. And so those cutoff scores are based on the not modified Bishop scoring.
Oh, okay, very helpful, because in my data, when I collect the data myself and published that study, that was 105 nulliparous mothers in Guangzhou, China. So I compared the before score with the transperineal ultrasound. So you are right to assess not just the length of the cervix, the dilation of the internal odds of the cervix. That's critical, because sometimes just use a finger, to subjectively assess. It's hard to know the dilation of the internal odds. So I really appreciate you sharing your work, and then maybe that specific measures of ultrasound assessment of Ripening could be, it's more advanced right now using that method. I wonder maybe in the future can look in detail about these measures, because this may explain the success of the induction label, because the more objective measure of the cervical ripening.
Right.
Thank you.
Yep. Thank you.
Great.
All right.
We have another question coming in from Stefka. Do hospitals that have higher cesarean rates have higher acuity pregnancy comorbidities?
So I think I'm going to take a little bit of a stab at what you're asking. And I'll refer back to the table that I showed you that showed, those that do more inductions have also overall higher cesarean rates. In that study, and I didn't explain this with great detail, I was using a stratification system that the World Health Organization uses. It uses 10 groups exclusively, 10 exclusive groups that stratifies all pregnant women based on their risk. And so there is a category for preterm births, for non-cephalic presentations. And so it brings those initial categories into a low risk sample. So it is a risk adjusted sample that you're comparing. And so then then you can also see the overall contribution of each of those groups to the cesarean birth rate. And so typically most medical centers have high risk birth categories that range between 8 and 12% of their patient population. So even when you take into account the proportion of what you would call higher risk births into that sample, there still is a meaningful difference in the use of intervention like labor induction. So I think what overall it supports is that if the culture of birth of an institution is supportive of vaginal birth and spontaneous labor, they also have overall lower induction rates that contribute to those lower cesarean rates. And it also, using that stratification system is also helpful to see is how many women who've had a prior cesarean birth and a repeat cesarean birth contribute to an institution's overall cesarean birth rate. And similarly, as you might speculate, that hospitals that are supportive of vaginal birth overall also are supportive of trial of labor after cesarean and are more successful at achieving vaginal birth for women with prior cesarean. So it then again lends itself to that there's a culture of care within institutions that's overall more supportive of vaginal birth all the way around. I hope that answers your question.
Thanks. And I did pull Stefka up. Stefka, you are able to unmute if you have any other comments or additions to that question.
Yeah, great. Thank you very much. Yeah, I was thinking more of it seems I've been at Denver Health for 15 years, including my training there. And it seems over the years, our population has gotten progressively sicker, so to speak. From past studies, the mean BMI is 36. And with that come, all the varieties of diabetes and hypertension and so forth. So we do have a lot of medically indicated inductions, not so many elective inductions of labor. And I was just wondering how that plays a role into the cesarean, which I know it increases it, but just wanted to hear your perspective.
Yeah, I saw a really fascinating study that was published about a year and a half ago that looked at the trends of more maternal comorbidities over time and the change in cesarean birth over time. And there's, kind of to oversimplify how they designed the study, all of the change in maternal morbidity does not account for the changes in cesarean birth practice. So, so there isn't like a rise that's corresponding. There's still lots of unnecessary cesarean births. Yep, I will find it.
Dr. Smith, I know that does come up in some of our hospitals that are participating in our quality improvement initiative. And really, I don't know if you have any comments about, adjusting for those things. Like we'll hear providers or hospitals say, our population is very different, right? Whether they age of 40 or like Stefka mentioned, BMI and other things, other factors. And so I wonder if there's any advice or information on, how do we adjust for that? So we're comparing apples to apples, so to speak, when we look at different patient populations and still look at the number of NTSV, that rate.
Well, I've got a couple of comments about that. And one of them that I think is really fascinating is that the lowest cesarean birth rates occur in hospitals with higher levels of care and higher maternal comorbidities. And so that's in observational studies. And so then, if that our patients are sicker hypothesis really played out, then you would see the highest rates of cesarean birth in our largest medical centers where they care for the sickest patients. But that's actually, it's the inverse that plays out in the observational studies. And then secondly, I think that also it highlights the importance of using risk stratification and risk adjusted comparisons, and why the World Health Organization has endorsed using the Robson 10 group classification system to stratify births for benchmarking and audit and feedback mechanisms. So then you can actually see the differences in the sick populations across centers. And if I were to put up the table, the entire table that I kind of showed you a snippet of, you would see that, that group 10, which is, what you would call the highest risk patients, that group size does not necessarily correlate to the outcomes within that institution. So, so far, our patients are sicker claims don't really pan out in the literature.
Thank you for that. It is always something we struggle with internally, is like what's the right data to look at, and how do we really make adjustments for that in our quality improvement work. So thank you. All right, we just have a couple minutes left, so I'll just ask the audience if there are any last questions. Feel free to put those in the Q&A or the chat. And if you want to verbalize those or have some discussion, we can bring you off mute. All right, we have another long question, and maybe it is helpful for the audience if we review that. So we could, Denise, I don't know if you'd like to just verbalize that. We can bring the participant who has that question or comment off mute again. Let me go do that if there's any discussion that we want to have about this last comment.
Yeah, maybe just read silently, will take less time.
Oh goodness. I mean, we could do a lot of things. I think, I as opposed to directly answering, what you've are mentioning about Colorado, I think it's, when you look at the state quality collaboratives and the infrastructures that they've built out, I think most people in the quality improvement, around perinatal quality improvement, would say that California really has a model program. And there's some really important aspects to note. And one of them is that, the CMQCC has been in existence for, I think, 15 years now, and is supported with a significant amount of funding from not only the state of California, but private foundations. And it's taken a really large amount, an enormous amount of work to create a system like that. And so, in any place in the country, it's going to really take, a lot of attention, a lot of resources to be able to do something at that magnitude. And anybody who's done any of these projects in promoting vaginal birth across their own institutions can acknowledge that it's hard to even get your own group of 50 or 25 people together to move the needle on something. It really takes a lot of work and a lot of dedication. And even sometimes it takes creating a whole new team of people to be able to change the outcomes in a particular institution. So I think it's a great and admirable goal. And I think all of us who work in this field, when given the opportunity, will and need to advocate for the public health attention on reducing cesarean birth and improving maternity care across the spectrum.
Yeah. Thank you, Dr. Smith. I think that was the perfect wrap up for today. And as I mentioned in chat, I know some folks probably are already starting to drop off the call. We will post the webinar, a recording, the slides, and link to all the resources. And we will send an email for all of those who registered for today for you to have that in your inbox as well. So thanks again. Great conversation. Great content and information. Dr. Smith, we really appreciate you being here with us today and look forward to seeing you again soon. Thanks, everyone. And for more information about supporting vaginal delivery for low-risk mothers and CPCQC, feel free to email us at info@cpcqc.org. Thanks, everyone, and have a great day.